Hey everyone, so we're here with Professor Michael Talbot. Thank you so much for joining us. We're
My
really
pleasure.
looking forward to this. So before we get into our actual topic, would you like to just maybe tell us a little bit about why you got into bariatrics and the amazing work that you're doing?
I got into bariatrics quite some time ago, before sleeves and bypasses were being done much here in Australia. When I was doing my final training as a surgeon here, part of what we do is an exit exam where you have to know everything about everything. And I did a lot of reading about bariatric surgery and what was going on, especially in the US. And that seemed really interesting because there weren't any places doing any type of weight management for people with diabetes and sleep apnea and other problems like that, either medical or surgical. So it was a completely foreign land. And every time I had conversations with my seniors and mentors about the topic, they all said, no, don't go anywhere near it. It doesn't work. It's witchcraft. And the patients, it doesn't work on the patients because they'll blend Mars bars and things like that, and they'll cheat the surgery. So part of my training, once I'd finished my training here, I decided to spend some time working overseas, and I made a few choices about different things that I would do for the training. And some of it was training in cancer and endoscopy over in Glasgow, but I also organised to visit a fair number of bariatric surgical units as well as cancer surgical units once I'd spent 18 months in Glasgow. So I spent some time with a chap by the name of Mal Phoebe in LA, who was one of the first people to design the modern gastric bypass back in the early 90s. And what I saw was, of course, very impressive because I saw all of these people who'd previously been 140, 150, 160 kilograms with diabetes and heart failure and developing kidney failure, who were just bouncing around in the follow-up clinic looking like normal people. I thought, well, obviously the data was right. This stuff does work. And so I went around learning, looking at all the different techniques. And when I arrived back in Australia to start as a consultant in 2003, there was another surgeon who'd also been away and had worked in a hospital in Sweden where they were doing gastric bypasses. So we both started doing procedures together. And in those days, it was really the laparoscopic band, and we were doing open gastric bypasses as well. And then the following year, we decided that we should switch from open to keyhole bypasses. So we went to the States and picked up, modified our technique for keyhole bypass, but at the same time stumbled across the sleeve gastrectomy. There was a surgeon that we went to visit who'd done about 30, and we thought, oh, actually, this sounds like a really good idea for the people where a bypass might be risky or challenging. And when we started doing them, on our harder, more difficult patients, because we were very concerned about safety, we found that a whole lot of patients didn't need to have a follow-up gastric bypass. They were basically fine. And then by, I guess, early 2005, I'd done 100 of the things.
Wow.
And then very soon after that, because we've got trainees at our hospital, we started to train more and more people. And before you knew it, the sleeve and the bypass has sort of taken off. It took quite a while, but it was very gratifying to be there in the early days and to see it all work. I like it because from a technical point of view, and I'm a technician, the technical aspects are very satisfying because it's hard, you have to think about it, but if you do your planning correctly and you make good decisions, you get good results. If on top of that, we get people who have spent their life being overweight, tried many things, have spent their time being told it's all their fault, then you offer them a treatment that actually works. Most of our patients take on new lives. They become new people. They become the people that they've always wanted to be, rather than people held back by a disease that's got control of their life. And that's a really gratifying thing to do. It's why you get into medicine, to do complex things if you've got, a desire to do complex things, and to try to help people get good results for their life. So it's been a very satisfying journey, really.
Yeah.
Well, we're we're very thankful for all of the hard work that you and your colleagues have put in, because it absolutely changes people's lives. We're
It does.
testament to that, and we know thousands and thousands of other people are too. So thank you again.
Yeah,
My
yeah,
pleasure.
it's amazing. So we've sort of talked a little bit over the years that the sleeve was sort of do that first and then go to bypass, but finding people that responded really well just to a sleeve. I mean, I lost over 100 kilos and I've maintained nearly all that for 11 years. So
Yeah.
I love the fact that I had the sleeve, and even though I'm getting reflux, I'm just looking at options to fix the hiatus hernia, and if I don't have to go to a bypass, I really would rather not. But there are so many people that we see that needing revision, they might be 2 years, 3 years down the track, and they're looking at getting revisions for all sorts of reasons. Can you walk us through what that might look like for people?
Okay, first up, everybody responds differently to a treatment. So if you imagine, we've all done maths at high school, the bell curve distribution,
Yep.
that there's a cluster of people in the middle with the mean or average result. There's the really strong positive outliers who've done better than expected, and then there's the negative outliers who've done less well than expected. So for a sleeve gastrectomy in Australia, the average weight loss is for people to lose around about 30% of their starting weight, or a third of their weight. So if you're 150 kilograms with the sleeve, if you're Mr. or Mrs. Average, you might lose 50 kilograms. But if you are lucky or young or fit or the combination's right, you might lose more. If you're unlucky or the timing's not right or there's other things going on in your life so you can't focus on the treatment quite as well, you might lose less. And probably maybe 10% of people who have a sleeve will lose less than 15% of their starting weight. And if you lose less than 15% of your starting weight, probably won't have a massive impact on your life and your function. You might lose a few clothing sizes, but you probably won't be able to transform the exercise that you do. Also, what we see with all weight loss treatments is that over time, the body adapts to the disruption that the treatment causes, and people regain a little bit of weight. You might lose 30%. We expect people to lose around about to regain about 5 or 10% over 5 years. So if you've lost less than 15% of your starting weight, you'll actually be more likely to regain weight. And some of the people who've lost 20 or 25% of their starting weight will regain at a faster rate. And when we look at average results for large studies, we see there's a cluster of people who fall outside the average range who probably need extra therapies. Now, on top of the weight loss being on a bell curve of distribution, side effects are also on a bell curve of distribution. So if you're in the middle, you've got some side effects. The sleeve, for example, makes your stomach quite tight, holds a bit of fluid at the top of it, which can then make you predisposed to a bit of reflux. But for most people, the reflux is pretty easily controlled and not much of a big deal. You've got some people who are lucky who go, reflux? What are you talking about? And others whose experience of reflux is a little more complex and a little bit less pleasant. And for those people, you need to find a cause for the reflux. And because reflux is actually always caused by something, it doesn't arise by itself. It arises because of an issue related to fluid and pressure flow. So basically, if the pressure in your upper stomach is greater than the pressure in your esophagus, fluid will leave your stomach and go up your esophagus. So the normal stomach has a very low resting pressure, but we measure these things in millimeters of mercury. So your blood pressure might be 120 systolic pressure. The pressure in your stomach is sort of 5 or 10 millimeters of mercury. The pressure in your esophagus is easily maintained in most people above 40 millimeters of mercury. So if there's fluid in your esophagus, it just gets squished into the stomach and doesn't come back. The
Yep.
problem with the sleeve is because it's tighter, when you put fluid and food into your stomach, the pressure goes up, and it's possible then for things to be reflected back up. But for most people, anything that bounces up into their esophagus when they eat and drink just falls back into the stomach again when the stomach empties and they're fine. But if your esophagus is weak, because it doesn't have much power because the muscle's weak, or if the seal separating the abdomen and the chest is broken by a hiatus hernia and the stomach slipped up into the chest, or if there's a narrow point or asymmetry in the stomach, so your stomach behaves like an hourglass, those three things will lead to increasing reflux symptoms for that individual. So if somebody has a weak esophagus, sometimes all you can do is a bypass, because a bypass reduces the pressure in the stomach. But if somebody's got an asymmetry in their stomach or they've got a hiatus hernia, we've found you can actually correct the reflux in most by just doing a hiatus hernia repair, but doing more than that, not just closing the hole that the stomach has slipped through to get into the chest, but pulling the stomach out of the chest, closing the hole, reinforcing the hole with a bit of mesh so it doesn't stretch open again, and sewing the esophagus back onto the diaphragm so it doesn't pull the stomach back up. And when we've looked at that, we've found that 90% of people who have that treatment don't need to go on, at least in the short to medium term, like months, several months, like a year or so, aren't knocking on our door asking for further treatment. Even if they've got a little bit of reflux, they're happy on a tablet rather than being unhappy on a tablet. And even if you do a bypass on somebody, most people still end up needing to take a tablet because the bypass, if you've got a weak esophagus, it's still got acid in it. So the only way you can get rid of acid completely is to chop out the stomach completely. And that's too big an operation just for reflux. It's just not worth it.
Wow. That makes so much sense.
It really does. Thank you. That's a really great explanation.
So if somebody comes in with reflux, you look for the reason why this person has reflux. And there's a couple of tests you can do to sort that out. And when you've found the reason for it, then you can give the person the options of either treating the reason, or you can still do a bypass. But bypasses aren't perfect either.
No, they're not. I mean, I've had a bypass. I had it 7 years ago, nearly 7 years ago, and I'm going in for a revision because I've got candy cane.
Okay.
And I've also had reflux the entire time, and my surgeon's going to do a fundoplication.
Yeah. Yeah, so no one operation's perfect.
That's right. Then.
And so if you've got something that works, stick with it.
Yep, exactly.
Yeah. Yeah, because initially I was sort of determined, I'm going to go and get the bypass, and I was even sort of hoping, I might lose some more weight as well. But I've seen so many people that have other issues that arise after bypass, and I was just like, you know what, if we can just fix the reflux, I think I'd rather try that first.
Yeah, look, and certainly, everybody who's had a weight problem, who's had a little bit of weight regain or is struggling to maintain their weight, has a pretty reasonable desire to look for things that might aid them to lose more weight. I mean, could you blame them? The one issue we have, though, is that when we look at the outcomes from procedures to try to achieve weight loss in people who've had sleeves and bypasses, the weight loss results are actually not that flash. So if you reoperate on somebody who's had a sleeve or a bypass with an intention to lose weight, the average weight loss is closer to 10 to 15%, rather than the initial 30 or 40%, because you're not performing a majorly transformative procedure. So when you're turning a sleeve to a bypass, you're turning a very small stomach into a slightly smaller stomach. If you're doing
makes sense.
If you're doing a pouch trim on a bypass, you're turning a very, very small stomach into a very, very, very small stomach. You might be reducing its volume by 20 or 30 cc's. Or if you're lengthening a bypass, you're going to be turning a small bowel bypass into a longer small bowel bypass to try to get a bit more of a metabolic effect, but the effects are always going to be relatively small. So while we do undertake weight loss revision surgery after sleeves and bypasses, it's similar to the reflux thing. You've got to ask yourself, what's leading to this person's problem? And will an operation fix the problem? Or how will an operation fix the problem? So if somebody's got an issue, for example, if they've had a gastric bypass and the old stomach and the new stomach have joined back together again, it's called a gastrogastric fistula. And those patients will often regain weight. It's a very easy solution because you just divide the join between the new and the old stomach and you give them a new stomach back that's small and they're off on their way. But if somebody's got an anatomically correct small stomach after a bypass, then you have to look for other things you can do rather than surgery to try to get them to lose weight, which really just means how do we get them to use their bypass?
Yeah.
And what we know these days is that because we've got so many more tools in our tool belt, that sometimes non-surgical therapies are a really good way to do things, or at least a very good way to start. Because if you've got a complex problem, why not use every single tool in your toolbox? Why just rely on one thing?
Yeah, amazing.
I totally agree.
Do you get very many people that have sort of gone band to sleeve and then they're coming back for a bypass?
A reasonable number, and that's always a bit of a disappointment. The sleeve is a great operation. It really is very good, but it doesn't perform well in people who have had previous gastric bands. So if you do a bundle of sleeves on people, you'll find 90 to 95% of people are pretty happy with their outcome. And there's not that many people back for early reoperative surgery. When you do band to sleeve surgeries, you find that the early return for further surgery is about 20 or 30%. And there's a couple of things going on.
Yeah,
One
so
is that
why is that?
the weight loss from a band to sleeve is closer to 20%.
Okay.
So rather than 30%. So if you're 150 kilograms and you have a sleeve, you might lose 50, you'll be pretty happy. If you're 105 kilograms, 95 kilograms, 110, who cares? You'll be okay.
Yeah.
But if you're 150 kilograms and you've had a band and then you have a sleeve, you'll probably be, not as good. You've lost 20%. You might lose 30 kilograms. You'll be 120 kilograms. If you're 120 kilograms, the problems that you had at 150 kilograms are still going to be there. Also, because the band disrupts the function of the esophagus and the upper stomach, people are more prone to reflux. So the reflux rate is significantly higher, enormously higher. So early reoperations for reflux after band to sleeves is very high. So if I've got somebody who's had a band who then wants a sleeve, what I insist is that they have a test of their esophageal function done. So if their esophagus is no longer able to squeeze more than that 40 millimeters of mercury pressure, then they shouldn't have a sleeve, because the sleeve, because it generates pressure that often is more than 40 millimeters of mercury, will give them reflux on day one.
Wow.
Okay. Well, there's the explanation.
Also, they've got to be, light enough to succeed with a 20% weight loss. And then people can choose what they want, because somebody may say, well, I really couldn't have a bypass for whatever reason. Anything's better than nothing. And I'd say, sure, we'll do a sleeve, we'll take care of your esophagus, and we'll put you on some medications after surgery to try to get another 10 or 15% weight loss on you. I wouldn't give up. But if you tell people what the outcomes of their choices are likely to be, then you empower them to make decisions.
Yeah.
I love that.
Yeah, and that's fantastic, because we do have a lot of people that they say, I'm going to see my surgeon, I'm just going to let my surgeon decide what I need. And we're like, go and get all your options and work with your surgeon to find out what the best for you will be.
Because they have to live with it.
Yeah, so we get to control our choices, but we don't get to control the consequences of our choices. So the more we know about the potential consequences, the easier it is to direct our ways around the minefield of seemingly multiple options. So you can actually
Mm.
make people's choices a lot easier for them if you take them through the story of what the average might be. So the average with the weight loss and the average with the side effect profile.
Essential, absolutely essential to know. And this is just a curiosity, I suppose, for myself, because I did have a gastric band. I had a lap band. I had that out, had nothing in there for 10 years. I was quite traumatized after the whole process.
Yes.
And then
Yeah, the band was very safe, but it really was the most side effect prone of all of our
yes,
surgeries, which is why it dropped out. Once patients of ours who'd had sleeves started walking around with their mates, having dinner with their friends who'd had bypasses, so bands, it was clear that the band wasn't going to last. It was a side effect
yeah,
profile that
yeah, well,
killed the band.
mine slipped.
Yeah.
I had a total gut obstruction, blah blah blah. All the very common side effects. But it took me 10 years to go to a gastric bypass. And
Yep.
the bypass was recommended to me because I was prone to reflux after the band. I had
Yep.
a tiny little bit of reflux before, but is it then just likely that perhaps with me the band did some sort of something to my esophagus, and that's okay.
Yeah, we've done a study because I often do esophageal function tests on people. I've got a lab,
I find that
and
fascinating.
I've studied the esophaguses of hundreds and hundreds of people before and after weight loss surgery. We do see a reasonably high rate of abnormal function in people's esophaguses after the band's been removed. And some of it's anatomy, some of it's change in function. The esophagus becomes a bit stretched and can take on some, abnormal contractility. Yeah, so band to bypass, I was saying the band to sleeve is a 20% weight loss on average. Band to bypass is closer to 30 or 40%. So if somebody's not super heavy and their esophagus is okay, then a sleeve might be fine. But it certainly is the person's experience of the weight loss journey with the bypass after a band is a little bit easier, I think, than with a sleeve.
Well, it's certainly been very successful for me, and the revision has absolutely nothing to do with wanting to lose any weight. I'm
Yeah,
actually
just getting rid of the
concerned.
regurgitation from the candy cane. Yeah.
Yeah, exactly. I'm concerned that I may lose 10% of my body weight. I don't want that to happen. I'd be very happy for none. Zero weight loss, thank you.
Yeah.
I wish we could put in our order like that.
Yeah, it's just difficult because surgery's like a tablet. You don't know how it'll affect you.
Exactly.
But which is one of the risks, and it's one of the reasons why people are a bit standoffish. And a bit of it's because they hear a bad story, but they don't know how the bad story fits in the whole, data of it all.
That's
So
right.
a 1% complication rate, isn't a big deal, apart from if you're that 1%, because it's 100% for you. So people's stories of problems, you certainly can't dismiss them, but they're not everybody's experience.
That's exactly right.
And as we all know, people with weight problems very frequently end up dying in emergency departments and nobody ever thinks anything about it.
Yeah.
End-stage renal failure is the most expensive healthcare service for the Australian hospital system, and the commonest cause is diabetes.
Wow.
And
Okay.
if you do, for example, a sleeve or a bypass on a diabetic, within 5 years of them becoming a diabetic, 70 or 80% resolve. So, we should be offering our type 2 diabetics in their 50s the option of avoiding dialysis in their 50s.
Yeah,
Yeah.
absolutely.
By getting rid of their diabetes, but that's a complex treatment for people to take on, especially since most of their life is okay. Diabetes doesn't make your life a misery if it's well controlled, but the future, aspects of it, so, vision loss, losing limbs, heart attacks, strokes, all of those sorts of things in the future, they certainly are there for our diabetics. But it's a big choice for somebody to have a complex treatment to prevent a future problem.
Yeah. I mean, I was on 350 units of insulin a day
Yeah.
before my surgery, and
So do
within
you think you'd still be here now if you hadn't had it?
no, my endocrinologist actually came in into and she said, Damo, we're doing everything we can. You're going to be dead in 5 years' time, the way it's going. And I said, can I get referred for weight loss surgery? And she said, no, well, they're not taking patients at the moment. So we ended up, I had to get private health, and even that's a really daunting thing when you're too sick to be able to work, yet
Yeah.
you take to get private health. My wife actually crocheted blankets to sell so that we could raise the money for my surgery, and within 6 months I was off all the insulin.
Yeah.
It had,
And now you've got it back because you can work and you can. So
Exactly
an
right.
early investment, it does seem expensive, but the fact is it's an investment in your own health and it keeps you
yeah,
working. I mean, you'll be able to work well up until you're the age of 65 or beyond if you choose to.
yeah. So we get some people, and we've seen it more recently where people are having or wanting to know about a bypass reversal. And I mean, I don't really know a whole lot about it because I've just never really looked into it. But can you walk us through what that looks like?
Not something we do very frequently. I've been doing, more than 100 bypasses a year, most years since 2005. Makes me feel old now. And I've had to reverse, 10 or 12 people. So it's about 1 in 100, 1 in 200, maybe.
Yeah.
And there's a range of reasons. There's a couple of common themes. One theme is hypoglycemia or low blood sugars. Having a bypass increases your glucose absorption and improves your insulin sensitivity. So what happens normally when we eat some glucose or carbohydrate, our blood sugar goes up, and then we secrete insulin to drive the blood sugar into your cells so it can be used. In diabetics, type 2 diabetics, they produce insulin, but the insulin doesn't work. So the blood glucose doesn't go into their cells to be used. It just circulates in their system because they need more insulin than what they're producing because the insulin's not working on them. With hypoglycemia, what happens is that because the insulin sensitivities improve so much, the insulin you produce is too much for the glucose that's in the bloodstream. All the glucose disappears into your cells, your blood sugar drops, and then you lack sufficient blood sugar for important functions, mainly the brain, because your brain runs on glucose. So it causes fatigue, dizziness, and when it's really bad, when people's sugars go down below 2 or 3, you can get seizures. And
Wow.
so hypoglycemia after carbohydrate foods is a fairly recognizable thing for a lot of people who've had gastric bypasses, but most can just moderate it by simple dietary changes. They learn not to have sweets. They learn not to have white bread. They alter their diet and they auto-regulate. People just do it automatically. If you do something and it's not pleasant, you just do something else.
Yep.
People aren't dumb. But there's a small percentage of people where their physiological response to insulin is too great, and then you've got to reverse them. That's one group. There's another group who just get funny side effects with their bowels, like wind and farting and diarrhea and stuff. They get what's called FODMAP symptoms. They become intolerant to carbohydrates and they bloat and feel uncomfortable. That's a relatively small number of people, but I've certainly seen that. People get smelly farts and they just don't want to have smelly farts. And then the third group is abdominal pain. People who get recurrent or chronic abdominal pain will sometimes need reversal, especially if you're on opioid or opioid-like painkillers. The issue is that opioid painkillers change your gut function, so you get a lot of gut spasms. Gut spasms cause pain. People take opioid painkillers for their gut spasms, and so on and so on. So the painkillers make their pain worse, but people can't stop them. So chronic opioid use is incredibly dangerous for a lot of people, but it's very dangerous for people who've had gastric bypasses because it can really stuff them up. So that's the other group.
Wow, that's really interesting because like I've had over 30 spinal procedures since I lost my weight. All the doctors would say, lose your weight, your back pain will go away. Mine got worse, and I went down the surgery path and ended up, I've got rods and screws and cages, and I got nerve stimulators. I used to be on like 220 milligrams equivalent of morphine a day. And I just think if I had have had a bypass and got those other symptoms with that, that would have just been absolute nightmare.
Most people don't, but some people do. It's one of those things, luck of the draw. If you get those
Yeah.
symptoms, then it can be a real struggle for people. So when you're reversing a bypass, again, it's all the other things. What problem are you trying to treat? There's actually several different ways of walking away from a gastric bypass. At one end of the spectrum, it's relatively simple partial reversals, and at the other end of the spectrum, you can return people back to their pre-existing anatomy. So the simplest thing you can do when you've got a bypass, you've got a small stomach and your old stomach is sitting there doing nothing. There's two different surgeries you can do to just replumb your old stomach, new stomach, either directly or by sewing what's called the roux limb into the stomach. And those are called single anastomosis reversals. You can reverse a bypass towards something that's like a sleeve, or you can reverse it back to the way it was before. One of the problems with a full reversal, and full reversals is something that I only do very, very, very rarely, I've only done it once, is that the stomach often doesn't work as well, and people are prone to bloating and discomfort when they eat because their stomach doesn't empty properly. Also, they get their weight problem back, and then you've got all these railway lines, staple lines in their stomach, and it becomes incredibly risky to try to then do another bariatric procedure on them in the future. So usually if people are seeking a near total reversal, I'll reverse them something similar, like anything from a quarter sleeve to a three-quarter sleeve, in order to leave them with a little bit of restriction, but also to try to protect them from bloating and reflux.
That's great because we've had some people say, "Oh, is a bypass reversible?" And my response usually is, "It depends." And you need to talk to your surgeon, but also you need to talk to a surgeon that can actually do a reversal. And I guess that leads me to another question. What should we look for when we're looking at clinics or a surgeon, picking a surgeon? There's so many out there, and I know one lady. She had a band put in just 4 or 5 months ago, and I was like, I didn't even think they were still doing them. So,
they still exist. Not that many. There's probably only a couple of hundred Australia-wide a year, but they still exist. Look, the most important thing is look for a bricks and mortar place, a doctor rather than some sort of internet-based virtual clinic.
yes.
Because if it's an internet-based virtual clinic, it's like a purchaser-provider interaction.
Yep.
You'll say, I want this procedure, and the person will say, sure. It's how many $1,000. Whereas if it's a bricks and mortar building, then you go and you see the person and you say, I've got this problem. What sort of solutions are there? And the person then isn't trying to sell you a product. They're letting you know what your options are. You can do this, you can do that, you could try this, you could try that. It's more relational rather than transactional. So if it feels transactional, not relational, then don't do it. The only exception to that rule is for our patients, cohort of patients who are rural. Then it becomes more difficult because there won't be somebody within a 10-minute drive or a 30-minute drive of where you live who either can do the surgery or could do the surgery that might be the right thing for you. If, you might find a surgeon who's happy to do one option, but doesn't know anything about the other options, so can't offer them. So that's the exception to the rule. Relational, not transactional. And somebody who seems to have a commitment to it and who's interested in being part of your medical care going forward. So the surgery should be something that involves at least a 3-year relationship with the clinic, because everything changes in 3 years. So the amount of change between the first month, 18 months is significant, but there's a lot that happens after the 18-month mark. People have lost their weight, but they often don't know. They think they've got it made, but they don't. A lot of the problems with weight loss surgery occur after that 18-month time. By about 3 years, most people have got a handle on things. But if it's a bricks and mortar place and you've got a relationship, then there's always somebody you can call if there's a problem in the future.
Yeah, I love that. Love it. Now, the other topic that we were hoping to cover was a question that gets asked a lot about non-steroidal anti-inflammatory medications, because some of us are educated by our surgeon that we can't have them, or they do carry some risk in taking them. What are your, thoughts on and experience on that?
Yeah, look, anti-inflammatory medications are a wonderful pain management tool for people with acute and chronic pain. So simple analgesics like Panadol and anti-inflammatories are wonderful medications because they work well, and for most people the side effect profile is very low and they work well together. So Panadol is good, anti-inflammatories are good. Panadol and anti-inflammatories together are 3 times better than each standing alone.
Wow.
So, but the problem with anti-inflammatories is that they contain a risk, and some people are vulnerable to that risk becoming an illness. So there's 2 things that anti-inflammatories do. One is quite uncommon. They change a little bit the blood flow inside your kidneys, and for a small number of people that can lead to a risk of acute kidney injury, especially if you're unwell or you become dehydrated. So that's a small but definite risk, but it's pretty uncommon. The most common thing that it does is by reducing the defenses against acid of your gut lining in your stomach, esophagus, and small bowel. So if you take regular anti-inflammatories and you've got a perfectly normal gut, you've got a 2 or 3% chance of getting pretty significant disease and bleeding conditions. But most of those conditions can be easily treated, so the risk and benefit balance works out well. I mean, every person with heart disease is on aspirin, which is an anti-inflammatory. Having a regular anti-inflammatory is a lot better than having a knee replacement. You should only have a knee replacement if the other stuff doesn't work. But if you've got abnormal anatomy, your risks are escalated. The 2 issues are, if you're prone to reflux, an anti-inflammatory will increase your risk of getting esophageal ulcers, but that risk for sleeve people is low. So if you've had a sleeve and you need to take regular anti-inflammatories, the overall risk profile is terribly low. You won't get an ulcer in your stomach or your duodenum because you're not producing enough acid. You might be a little bit more prone to reflux symptoms, but you can take a tablet, it'll be fine. For bypass patients, it's a bit more complex because when we do bypasses, we sew small bowel onto the stomach. Well, that stomach is fairly acid resistant. It's got a thick layer of carpet. The lining of the stomach is like carpet. It's thick and relatively acid resistant, but the lining of the small bowel isn't. So people will quite frequently get ulcers just where the join is between their stomach and their small bowel. They're called stomach ulcers, but they're not. They're actually always in the small bowel. And that risk is higher the more other risk factors you have. So you're more prone to get ulcers early after surgery before things are fully healed. You're more likely to get ulcers if you smoke or drink alcohol regularly, or if you're stressed, or any type of stress. Chronic or sudden illness will be stressful for your system, and that reduces the defenses of the lining of your gut against the anti-inflammatories.
Wow.
So you shouldn't take, if you've had a bypass, anti-inflammatories until everything's healed. If you're going to take anti-inflammatories, you really can't be a smoker or a drinker, but you shouldn't be a smoker or a drinker if you have a bypass anyway, because your risk of ulcers is so high. But you can take, if needed, anti-inflammatories if you're on a regular antiacid tablet like Nexium or Paret or something like that. And there's another medication for people who aren't tolerant of the PPI tablets called misoprostol, which is a medication that was designed specifically to prevent ulcers in people on aspirin. And there's another class of anti-inflammatories that I can't remember what the name of the class is, but that's Mobic or Celebrex. They're a lot less irritant on the gut. So if somebody needs to be on anti-inflammatories and they've had bypass surgery, they should all be on a PPI medication. And short courses are probably relatively safe. But if you need to be on long term, then looking at the ones that are less irritant, like Mobic or Celebrex, would be preferable. So the answer is complex.
Yeah.
So it's avoid it if you don't need it, but if you need it, then there's strategies that you can have to reduce your risk.
And that's the importance, isn't it, of keeping that contact with your surgeon and your team.
Yeah, unfortunately, we not infrequently see people who are perfectly fine, they've had a bypass, then they have a surgery, they break a leg or something, and they're dosed up to the eyeballs with anti-inflammatories, but nobody gives them any protective agents to stop the ulcers from occurring. Nobody uses the non-ulcerogenic version of the anti-inflammatory, and before you know it, they've got a major ulcer problem or a perforation of their gut. Most ulcer perforations, and they do perforate from time to time, are caused by anti-inflammatories that have been given without an anti-ulcer tablet. So
very good for people to know.
Yeah, it is. It is. So just, I guess we're sort of getting to the end, but what do you think patients need to know when they're planning or looking into having a bariatric surgery? Is there something that you wish that...
Yeah, look, it's a chronic disease. A surgery, even if you have the follow-up for a while, is a single episode of care. It's like having a prescription. You know, if you're a bad asthmatic and you have an asthma puffer, you will be better. But the moment you stop the treatment, the condition will recur. And the same thing with significant weight problems. The problem will occur if you don't make managing it part of your focus. So when you see an asthmatic, once they've just accepted it and gone, I am an asthmatic. If I smoke cigarettes, I'll be terrible. If I walk through a field of pollen, I'll be terrible. If I stop taking my medication, I'll be terrible. I'm just going to take my medication. Then they're fine. And it's the same thing when you're very overweight. The people who do well are the ones who go, let's cut the bullshit. I've got a weight problem. I'm going to need to manage it. Now, on the way, they've met people and talked to people and been offered different strategies. I mean, you can't just give people a brochure and say, go and do this. You've got to, it's impossible to individualize advice to somebody without knowing what their circumstances are. And no asthmatic ever gets better with one visit to a doctor. No diabetic gets better with one visit to a doctor. It's all about trying this, tweaking that, improving this, avoiding that. So it's the process of care. Now, the surgery is just part of that process of care, but it's not the whole deal.
I love it.
Yeah, that's great. And I love how you sort of bring in that, this can really work hand in hand for people with the GLP-1s and all that sort of stuff.
Yeah, look, and that it really is an important thing for people who are considering, therapy again after bariatric surgery is when you've got changed anatomy like a sleeve and a bypass, you do not regain weight quickly because your stomach's small and your appetite's suppressed. So if you so what we've found with people on GLP agonists is the very low dose, they can lose on average 10 to 15% of their weight on a standard low dose. Whereas in people with normal stomachs, to lose that much, you've got to go up to a standard dose, like for semaglutide up to 2 milligrams, where you can get the same result from 0.5 to 1 milligram in somebody who's had a sleeve or a bypass. And people tend not to regain their weight quickly because their stomach is small. Most people who regain weight after these surgeries regain weight as a result of a crisis. If you help them control their weight and you control the crisis, then they go back to the way they were before. So the good thing about these new medications is they're actually allowing us to find ways of treating people without going to further surgeries, or at least holding the further surgeries back until we know that they're really needed. People don't have to be as desperate knowing that there's so many other options.
I think that's really good to know that all of these things can work hand in hand with each other.
Yeah.
Just to provide that very much a patient-focused outcome that we can walk out over years. Because let's face it, once we've had bariatric surgery, you're kind of in it then for the rest of your life.
The rest of your life.
You're in it, basically, yes.
Yeah. No, that's great. Thank you so much for joining us today.
No trouble.
This has been awesome.
Looking forward to maybe if you give us some time again in the future.
Absolutely.